Thank you very much for having me. It's wonderful to be invited, and I've really enjoyed all of the presentations so far. I apologise if my voice sounds a little strange or I have to blow my nose halfway through because I have picked up a cold since yesterday. So I'm just going to talk briefly about my experience and our team's experience with the NEVA, actually, and we've been using it for quite some time. I'd like to pay a special thanks to Vladimir, who shared some of his data using the 4x30 NEVA net, which I will show at the end. And these are some of my colleagues in London. These are my relevant disclosures. So the NEVA has gone through several iterations over the years, and actually mostly what we've seen is a slight change in the design of the device and change in the sizes. And more recently, they've brought in to clinical use the first device which has actually got a true, what I would classify a true sort of distal capture device called the NEVA net. And that's a little bit, for anyone that does aneurysm work, that's a little bit like a web. So it's designed to sort of catch any microthrombi that might break off during the mechanical thrombectomy procedure. And I will come on to some of our data regarding that towards the end of the presentation. So the original time that I used NEVA was back in 2021, and like many first dates, there were good points and bad points. But I was definitely interested in a second date with Lady NEVA. So I'm just going to go through a series of essentially publications that are in various stages of being accepted. And this data has actually just been accepted, so it will be published shortly. And it's our first line results. So NEVA, when it's used first line, we had just under 90 cases, essentially unselected, just whoever came with an ICA, M1, and an M12 junction clot. The average age of the patients was approximately 73 years, and typically you'll see, most of the patients are MRS 0 to 1. In this group, approximately 50% patients received IV TPA if they met, international guidance. Cardioembolic strokes were most common. And as has been mentioned earlier, approximately 15% of cases were tandem occlusions. I tend to do nearly all of the cases with the BGC and aspiration as well. And now my colleagues have shifted on the whole to a similar technique. Mostly our cases are done under local anesthesia. And although there has been an iteration over size and device design in the last few years, what I found is the 4.5 by 29 millimeter device is the workhorse. It's a very good device for most of these occlusions. And what we found with that original sort of NEVA device was a first pass effect, so TICI2C3 in about 57.5% of patients, modified first pass in 65 if that's 2B 67, and 75% if you're classifying it as 2B 50%. And it's difficult from the previous literature to determine whether people were calling 2B 50% 2B or 67% 2B. I'm not quite sure from what has been written in the previous papers. But this aligns pretty closely with what other groups have published so far on the original NEVA. What we also saw was very similar results to final 2B and final 2C with the original device. And approximately 40% of our patients are reaching MRS 0 to 2 when we're using this device. So here's a sort of classic case. I won't bore you with it too much, but you can see the stent very nicely. First pass effect achieved TICI3, and then a very small subarachnoid hemorrhage seen on the 24-hour scan, the virtual non-contrast. So we know it's not contrast, and it was definitely a small amount of blood. So my key learning points from the original NEVA was that the tracking through a headway 21 is very good, visibility is good. Personally, I would say don't deploy it too distal, and what I generally advise everyone to do with it is make sure that you've got into the angular artery, so the largest branch, avoid the ascending frontal artery if you can, and then generally don't put the tip further than the mid-angular artery. So if you're in that sort of region, I think you'll have a good result, and I don't think you'll really see any increase in subarachnoid hemorrhage. I generally tend to leave the device for about 3 to 5 minutes, which was contrary to what the company actually said of you can deploy and immediately retrieve. that could explain why some of our results are slightly better than some of the publications. I don't think you have to stop and start, which was what the company originally said. I think you can just do a consistent pull like you do with other devices, and it works completely fine with the other pieces of equipment. One of the other analyses that we did was using the NEVA as a bailout. So if another device, another stent retriever had been used prior to the NEVA itself, and we've got 39 patients with an average age of 70, that's median. In this cohort, interestingly, and I can't explain why, it's probably just an oddity of the small numbers, but the majority of patients seem to be men. We had a low percentage of people receiving TPA in this cohort, so again, did that make an effect? As coming back to the TPA discussion, I'm not quite sure. But interestingly, we did see that still the vast majority of these cases were hyperdense on non-contrast CT, which typically suggests they're red blood cell rich, and which also suggests are they easier to remove. That didn't really fit with what we've seen in our own data. So a variety of different devices were used first line before the NEVA was used as a bailout. And in about a quarter of cases, another stent was used. So in about a quarter of a case, you maybe started with an embo trap, then switched to a solitaire, and then picked up the NEVA. What we saw was only 2 out of 39 patients had a 2B recanalization after the initial stent retriever, so let's say after a solitaire. That improved a little bit after another pull with the same device or another pull with a different device that was not NEVA. But essentially, you didn't really see a significant improvement in these cases. The total number of pulls, and this is the total number of pulls across both the non-NEVA devices and the NEVA, was ranged between 2 to 7 with a median of 4. What we saw, interestingly, was after the first NEVA pull, approximately 50% of cases showed an immediate improvement in the recanalization to TICI 2B or above, and 13 of those 18 cases actually went to 2C. After all of the pulls using the NEVA device, 74% of patients achieved TICI 2B or greater, and 54% of patients received or achieved 2C. The total number of pulls with the NEVA or median was 2, and the average pull on which the NEVA was first used was the third pull. Now, my experience here is generally, and this is sort of fitting with some of the recent publications that have come out by Diogo Hausen and a few others, is that if you have a static failure, so what I mean by static failure is if it hasn't changed at all, if the clot remains and the occlusion remains basically exactly the same, and I don't have a NEVA, then I switch immediately to the NEVA device. And that's the same if I have another, let's say a solitaire or whatever, if I pick something else up. If it doesn't change, I immediately switch techniques. So I might jump to aspiration only, or I might try a different stent retriever, etc. But essentially what I'm doing is very rapidly altering techniques to see if something else will remove the clot. And then if nothing has changed by the third pull, so by the third pull, if I've altered techniques at least to use one other technique, by the third pull, if it hasn't changed at all, then I bail out and I immediately angioplasty and stent. And I've personally have seen quite good results from that technique. And oddly, and I can't really fully explain this, I've not seen any bleeds from stenting intracranially, whereas I do see bleeds from stenting extracranially, and I can't sort of fully explain why that's the case. And then to the NEVA net. So I'm talking only about the NEVA net 4x30 here, which is the device that can pass through a 21 microcatheter most of the time. So this is a combined data set. It's a small data set of 20 patients. It's combined 10 from my center, 10 from Professor Kalusek's center here. All of the cases were done at my center. The majority all of them were sort of done with a BGC, and in Vlad's case, I think one was done with a BGC. All of the cases had an aspiration catheter, and it was exclusively the 4x30 Neva net. Vlad tends to use the Neva net in a headway 27. I tend to use it in a headway 21, and I'll come to a couple of interesting points about that as well. In two of the cases, and these are both my cases, through a headway 21, I couldn't track the Neva net, and I'll explain why I think that's the case. But the most important thing here is we saw a very high first pass effect. So, 90% or greater. We saw small subarachnoid hemorrhages in 4 cases. This is just a typical case. I mean, I hope that you can sort of roughly see the stent there. But this is a typical case. And this is where, for example, I couldn't get the Neva net to track around the cavernous ICA. And what I found in the headway 21 is if there's a lot of tortuosity, then you just can't push the device around all of the bends, and typically it tends to fail at this sort of cavernous bend. So you have to look a little bit when picking up the Neva net at what the anatomy looks like. And if it's very tortuous, you can still use the device, but you need to use a headway 27 or a 27 microcatheter. So generally what I've been looking for is, are there loops in the cervical ICA that I think I will not be able to straighten out, or a severe kink? And then what type of cavernous appearance do I have? If it's a type 3 or a type 4, I will probably go with a headway 27. If it's a type 1 or a type 2 cavernous, I think a 21 microcatheter is going to be completely fine. And that's my gut feeling at the moment. And then just to come back to the sort of what we've seen in our own institution and with Vlad's data set, I think personally that you are seeing a significant improvement in the recanalization with the Neva net compared to the standard Neva of an approximately similar size. And, there's a lot of talk recently about double SR and all the rest of these sorts of things. And our first pass effect, I appreciate that there's differences in patient selection, but the first pass effect that we've seen so far with the Neva net seems to outdo the double SR. So why have 2 swords when you can just pick up Excalibur? And that's about it. And I would like to invite everyone to Brain Conference, which I host in London each December, and we should have some very interesting novel topics to discuss, including cannabinoids and brain tumors and lots of other interesting things.
Thank you. Any questions?
I have a question.
Sure.
Your advice was not to put the Neva too distal.
Yes.
But the other advice that I heard was to put drop zones beyond the clot.
Yeah.
So how do you combine those two?
Yeah, so that generally only becomes an issue, I think, if you have an M1-2 or maybe a proximal M2 occlusion, right? I think if you have an M1 occlusion, yes, I have a few of the drop zones sort of distally, but it's only really a problem if you have a slightly more distal occlusion. And then what I tend to do is, I have about half of the device out into the angular artery, and the rest is sort of in the M1. And it seems to still work quite well, actually, in truth. The majority of those, I don't have that data, but the majority of the cases that we've used the Neva in have been M1s and ICAs, because that's basically mostly what get referred to us. But that's generally what I do. It doesn't really seem to be a big issue. So you don't have to have all of the drop zones distal to the occlusion. That's my take on it. And that's the same as if I'm using a solitaire or an embo trap. I sort of partially deploy the device, let's say. Anything else?
Post-procedure, is this possible fully same with
Yeah, so that's a good question. And the honest answer is I don't think I see it any more than I do with anything else. Again, I'm just trying to think if we've had any cases where... There was a case recently where it was with the fellow. I don't think it was with the Neva. Yeah, from what I recall, it wasn't with the Neva, though. And that patient had very bad vasospasm, secondary to the stent retriever. So we just gave a bit of nimodipine and, 30 seconds later, it was gone. So I don't think I'm seeing more vasospasm with the Neva. I could be wrong. I don't recall it. Let's put it that way. Anything else? Everyone's hungry and needs lunch.
Yeah.